So kia ora koutou, nau mai haere mai, and welcome to our second Rural Medicine CME webinar, brought to you by the Rural Postgraduate Program and the Division of Rural Hospital Medicine. I'm Matilda Hamilton, and this is our second webinar, and our first was a real success, and thank you for all the positive feedback that we've had, and we hope to keep building on that tonight. We are now an accredited CME provider, and tonight we're going to attempt to log your CME points following the webinar. To allow us to do this, at the end of the webinar, we'll ask you to complete a short survey, and this is firstly to obtain your medical council number, and also to obtain some feedback about the webinar and suggestions for future webinars. We won't store any of the identifiable personal information that you provide through that survey. Rory will post the link to this survey in the chat box throughout the evening, and the link will also be available through Leaning on Fence posts after we've completed the webinar. Just as last time, just a couple of housekeeping matters. If everyone can just keep their microphones off during the webinar, it just improves the sound quality, and Rory has control over that if we need to. And as this is quite a large group, rather than taking questions from people with their voices, we'll just get you to write your questions in the chat box over the course of the webinar. And Gary will collate those questions and feed them back to us as we go through the webinar. And there's also the opportunity to email me any questions after the webinar as well. So for our second webinar this evening, we have chosen the topic of mental health. The reason we selected this topic is that feedback from you has said that this is something that you would like to have discussed and learn more about. And secondly, we feel that it is a really important issue in Aotearoa at the moment that is finally receiving much needed attention. So with great pleasure that I introduce our two experts this evening. Firstly, Dr. Mark Lancashire, who is a rural doctor from the Hokianga. Mark has a strong interest in mental health and has practiced as a psychiatric MOS for many years. Our second guest presenter is Dr. Dan Allen. Dan is a psychiatrist based in Christchurch who has a particular interest in geriatric psychiatry. Although Dan is somewhat of a city slicker these days, his roots are firmly bedded in the rural world, having grown up on a farm in Ikawai near Waimati, where he still spends lots of time. Tonight we will aim to cover the topics of panic attacks, acute delirium in the elderly, and assessing suicide risk. These are all hefty topics in themselves, so we will see how we go, but the webinar will last a little longer than 90 minutes, and of course can be viewed at a later date through Leaning on Fence posts. So our first topic that we're going to discuss is panic attacks, and we're going to aim our first questions at Mark. So Mark, I was surprised, and I'm not sure if this is particular to Queenstown Hospital, how frequently I was faced with individuals experiencing panic attacks while working in the emergency department. And it's a problem that we face both in rural general practice and in our hospitals. If you could just spend a bit of time explaining to the group what defines a panic attack and a little bit about what an individual is experiencing when they have a panic attack.
Kia ora koutou. Thank you, Matilda. I think it's a great honour to be an expert. I'm very much a generalist, but as you say, I had a long interest in mental health. I'm going to just see if I can share a little diagram which I find quite helpful. And panic attacks, I think we're all familiar with the feeling of panic and anxiety, and we will have seen it. We've probably experienced it at some stage in our lives. It's a very common human experience, and I'm sure we will have seen it in patients. It is very common, and anxiety disorders generally are very common throughout the community. Probably is as common, if not more so, than mood disorders. And panic attacks are one little part of those general sort of wider anxiety disorders. And there are very discrete things, and I'm sort of just going on the definition of DSM-5, which people can look up. It's very easy. But so it's a discrete moment of time that starts abruptly. And if you in this diagram, it's the symptoms in the center, and you're supposed to have 4 or more of these symptoms. And I think, I always think of them split them a little bit into those kind of somatic symptoms, so the palpitations, the sweating, the trembling, the shortness of breath, which are all very much sort of adrenaline related sort of things. But there's also a sort of the cognitive component of that, that people experience. There's that fear of losing control, particularly, and of dying, and the cognitions that go with it. And then there are some physical things that seem to be very much, actually, these are real experiences that people have as a result of the adrenaline and the carbon dioxide changes, particularly those paresthesias and the cramps and the tetany that we sometimes see for people. So you've got a mixture of sort of perceived and real physiological effects, and then the cognitive component of those. So I'll probably just leave that up there for a minute or two. And I think it's really helpful to think about panic attacks. So anyone can have a panic attack, and we all do that sometimes. And that can be a component of an anxiety disorder. And particularly we think about panic disorder. And panic disorder is when you're having one or more of those panic attacks over a period of time, but also particularly your life can become a bit dominated by both the worry and the fear of them coming back, and you actually change your behavior to try and avoid the situation that's triggered those panic attacks. So that's panic disorder. And it's quite helpful to kind of clarify those two things when you're talking about people, because lots of people have panic attacks as a one-off. And then some people go on to develop panic disorder where that's frequently happening and they're actually trying to avoid them and change those things.
Yeah. And I think, sometimes we'll be seeing people after they've had a panic attack, they'll present after the experience, but sometimes you're actually there, as bearing witness to this horrible event. What suggestions might you give to someone, Mark, if they're dealing with a patient in front of them to help them, ease someone out of this experience or relieve them of some of that distress?
Yeah, and it can be very distressing, and it can raise your anxieties as well. And I think you have to be. I'm very conscious that we take an approach that doesn't miss the physical disorders, because clearly if someone's having a heart attack, they're going to get palpitations and fear. A lot of these symptoms are not discrete to just primary panic disorders, and I think it's very helpful to be having a fairly systematic approach to them. And like as with many of the sort of mental health disorders that we see, it's about having a therapeutic alliance, making really good eye contact and connections with people, and then being confident and systematic about your engagement with them and checking just basic things like pulse, oxygen sats, all those sort of things that we get really used to doing in an ED environment. And as you go through those and you're talking to someone, trying to get them to explain what they're experiencing, I think you get more and more of a feeling that you become more and more confident that this isn't a primary physical disorder. And there's something about the way people describe these and the way they talk about their experiences that gives you more and more clues that this is a panic attack rather than a physical illness. But you do have to systematically work through that exclusion of physical illness as the primary cause. And it really helps, I think, for people to gain confidence with you that you're confident in your own diagnosis of that, and that they feel safe with you. And I would really say to people, one of the times I learned quite a lot about managing panic disorders is actually doing some diving, and you could see people panic in the dive situation because you just see them hyperventilate and the bubble sort of surrounded by a huge cloud of bubbles, and you can see that in an ED setting. And what was really helpful there was just keeping eye contact, talking calmly, talking people through what's happening for them and what you're doing, because it brings it back into the present moment, and to try and make them feel confident. And I think that's a really helpful thing to be doing. Trying to make them feel safe and secure will help them do that. And really the key thing for me is trying to encourage people to take control of their breathing. And that's one of the points that you can intervene at, and that they can intervene at, to take control of their own physiological experiences. So trying to do those slow, deep breaths is really helpful. And you can do that one-to-one. So it's a very, a very human thing we can do in the ED departments and in the GP room. Just try and stop everything else, stop the conversation about everything else, just focus on that breathing. And I find that one of the most helpful things to do.
And I think you, by providing that advice, you've sort of in part answered my next question, which, I mean, when I'm seeing these people in the ED setting, and particularly if it's the first panic attack they've ever had, I sort of see it as an opportunity to educate people and to provide them with some kind of path that they're going to be able to manage this, because it's likely to happen in the future. Is there any other advice or some practical things around breathing techniques and perhaps resources that you might share with patients?
Yeah, so I mean, I think it's very individual, and you have to really keep that connection with someone, I think, who's in the middle of a panic attack. And so really a little bit of physical contact can really help, but that eye contact is really important, and trying to mirror. We're very good as human beings at picking up what's happening for the person in front of us and mirroring that.
Yep.
So if you mirror those breathing techniques and you actually breathe in, you can often find that person will follow you, and they're desperate to, they're in the middle of a panic attack, they're scared. And if you can do that really slow, deep breath, and I often find the simplest one is just counting, and just say breathe in with 7, just 1, and then breathe out with 7, and just 1, 2, 3, and just trying to slow it right down, and just telling them that they're going to be safe, and trying to teach them that slow breath in and out can be really, really helpful. And explaining to them, as you're saying, that yes, you are feeling those palpitations, but we know that that's okay. We've got the ECG there. It's okay. Your heart's okay. And it'll depend a little bit on what the symptoms they're experiencing, that you can start talking to those symptoms and explain how you recognize those. They're part of a panic attack. I mean, people can have a panic attack in the midst of a physical injury, but the panic will make the pain worse. And so you can talk people through that and try and still get them to get control of that breathing. And people do use things like the paper bags and things like that, especially if they're getting a lot of that sort of tetany and the spasms and things. But I would, and it can help because it can help people focus on their breathing. I tend to use that sort of second if I can't get contact with them in the first place.
Yep. And what kind of explanation do you provide for people about what is actually happening to them, so that they might understand it?
So I often talk about their breathing. I think breathing for me is one of those things that they can get hold of and they can change. It's one of those little bits of our physiology that we can connect with and we can take control of. So I can say your breathing is, because you're breathing too fast, it's making your heart race. So if we can slow your breathing down, that will help with your heart settling down. And the same thing, and I can say, look, I know your stomach's churning and you're feeling very scared, but this is all but you are safe here. Just emphasize that safety. We're doing everything that we can do. We're checking everything out, but you are safe. You're in good hands. And by helping take control of your breathing, you will feel better. So you can talk people through. And I think there's a real difference there. I think that thing about talking them through that initial panic, trying to get their breathing to slow down, get their heart rate to slow down, get their oxygen and carbon dioxide levels to be normal, and their body will start feeling a bit more normal. And during that bit of the acute panic attack, you really want to be just trying to get them through the panic attack to the other side.
Because I guess it's an opportunity to demonstrate to people that they can come through it and have some control over the winding down and the returning to some kind of normality.
That's right.
I guess, Mike, the other thing is that, there's been a real shift in our attitude towards prescribing of benzodiazepines. And what role do you think they have, if any, in the acute management of a panic attack and in the prescribing of patients who are going to leave your clinic that day or leave the ED?
I'd like to say I never use them. I think that's probably slightly unrealistic, and I think there are people who, particularly if they've had I certainly wouldn't use them first off for a single panic attack, and I'd try and manage it without medication because there's so many downsides to the benzodiazepines. But there are people who have really high levels of anxiety that you can talk them down, but they immediately go back into it, or you're really struggling to talk them down. And I do think there is a role for benzodiazepines there, but you have to, as you say, have a mind to what happens next then, because those benzodiazepines will produce sedation and potentially a bit of vulnerability and confusion over the next few hours. So once you've given someone a benzodiazepine, you're really committed to managing that period of time. And the disadvantage then is what the message that you've given them is that to manage this panic attack, what you need is this tablet that feels really good and it works really well, doesn't it? And they feel much better, but they're highly addictive and they don't help them build their strengths to manage the anxiety otherwise. But I do think they have a role, and there are some people for whom they choose or they cannot manage their panic attacks and their anxieties with just those cognitive and behavioural approaches, and using small amounts of benzodiazepines for limited amounts of time, particularly in crisis situations, it isn't unreasonable. But I think it's really helpful when you have to put some real expectations around the duration of that. And I always talk to people about the downsides and the addictive nature. And I think actually now these days people are so nervous of becoming addicted to the doctor's medicines that actually that's quite a useful thing to say to people, because then they get that actually they don't want to use this long term. No one wants to get addicted to medicines. So you can use them. They do have a role, I think.
Maybe, Mark, if we could ask Dan from a psychiatrist's point of view about drug selection, and if you were going to, or you felt it was appropriate to use benzos in the short term in a patient like this, what might be the optimal selection of benzos, if there is any that are better than others?
You're welcome, everyone. Yeah, I sort of agree with everything you said there, Mark. Yeah, one of the things I guess, of just stepping back a little bit, is if you're going to treat with a medication, I always think just make sure that you're reviewing what they're already taking, and also if they're on any substance or taking any substances, and that really needs to be canned. I think if they're drinking a lot of alcohol or something, or they're already using benzos, like a lot of my patients tend to do. But if I am going down the benzo line, which I'll do just about everything I can to avoid, to be honest, I use a longer acting benzo like clonazepam, and that could be something like 0.5 BD of clonazepam, rather than lorazepam, which people tend to use like a rescue remedy and get in a habit of using that. Probably the worst, the ultimate, is midazolam. Some people have got their carry around a bit of midaz spray, which I think is like the ultimate rescue remedy, and I think that can create real problems with coping, and of course dependence or tolerance, and needing more and more. I think the mainstay of treatment, if you're going down the medication line, is an SSRI, possibly a tricyclic, depending on the patient. But I just noticed on the chat there, someone mentioned beta blockers, and absolutely, I think that's a great idea. And I've used propranolol in the past, so it's really helpful to patients. And so I think I'd head down those lines first before I was using benzos. But way before the medication is everything Mark's saying about establishing a good rapport, and taking a non-pharmacological approach if at all possible.
And it's probably too big a topic to delve into tonight, but I guess a lot of probably people, particularly in general practice, are also dealing with the situation where they have patients who have a long history of this, who are already well established on benzodiazepines. So that sort of adds in another level of difficulty in how to move away from the benzos. I might just check if Gary has received any other questions with regard to panic attacks.
No, Dan's ahead of us, actually. He's already had a good look at the chat room and picked up on the one question that come through. Thanks, Dan. Yeah, I've got one other one just from myself that I might toss in there though, and that's around making use of a local physiotherapist, particularly when the breathing disorders are a big part of it. Whether you've got experience with that.
Yeah, we tend to do that quite. That's rather than us coaching the patient, we do tend to refer to the physiotherapist. I guess we're dealing with someone who's not presenting so acutely. In fact, my situation is I hardly ever see someone who's in the midst of a panic attack. The only time I've ever really seen that was when I was a fifth year medical student in Queenstown. There must be lots of people panicking in Queenstown, Matilda. But yeah, I think it all happens before they get to us, and then we're dealing more with withdrawing, getting people off benzos, making referrals to physiotherapists and so on, establishing them on a different medication, stopping the substances, that side of things, getting CBT going.
Yeah, I think that's right. And if there's really strong hyperventilation, it's a little bit about what skills, who's around that feels confident with managing it, and the physiotherapist can be very good at teaching those breathing skills. I think I see most of the panic attacks that I see these days is more in the emergency department than anywhere else in the clinics, because people come in either with panic attack as the primary thing, or panic as part of a social crisis or another injury or something. We see people presenting to the ED with panic.
So I think, Mark, if we could kind of summarise what you've said, it's if you're presented with a patient who's having an acute panic attack, is to really focus on connecting with that patient, being with them, and kind of almost modelling to them through remaining calm and slow breathing to try and work them through that situation, and utilising that as an opportunity to educate people.
Absolutely, and particularly that eye contact. I just think if you can get someone's eye contact and they'll engage with that really helps them feel not alone and not as safer.
I just saw a question from Lisa about palliative patients with panic, I think. Hi, Lisa. I think this is Lisa, who grew up in Ikawai with me. But I have had a bit of contact with palliative patients, particularly patients in the dementia setting, and we do tend to use midazolam in that situation if they're in the midst of, a palliative situation with panic attacks. But we also would potentially be using antipsychotics as well. But yeah, midazolam spray.
Mm-hmm. Or Rivotril drops are the other thing. If we need to use something like that, it's the other thing that can be quite effective. But again, if it's after you've tried the other things, I think, because you don't want to sedate people unnecessarily, and often actually, even if they can understand that this is made worse by the anxiety and they can take control of their breathing, if you can achieve that, that's a good way of doing it. I think it might be worth just mentioning some of the resources as well, Matilda, because you want to see people at that time. But the other thing I do as the panic attack settles is I really try and make sure that there's a follow-up in place. So you get through that attack, but then come back and see us, and we'll talk about how to stop these happening again when you're in a better place. And there's a lot of resources around people recognizing panic attacks and managing it themselves, both online and some of the leaflets that Compass or Northumberland have done. There's a lot of reading that people can do around panic attacks. And they often, my experience is they often come back really reassured, that they sort of recognize and think, oh, this is what's happening to me. Whereas before they were feeling scared and nervous because it seemed so out of control. Whereas if they can recognize it, and there's a particularly Compass, they've produced some very good online leaflets, and I often recommend Headspace as a phone app as well. But there's a lot of resources out there, a lot to be gained by reading.
Yeah, thanks, Mark. And I think I'm terrible at remembering things, so we'll include some of those on Leaning on Fence posts. I'll get some of those names because I think that's really helpful for people to be directed towards things which are thought to be reliable. Dan, I just spotted one more question that came up on the chat, and that was, as a psychiatrist who's receiving referrals, what can we do as clinicians, as GPs and as hospital doctors to make your life easier?
Wow. That'd be great. Maybe just look after them all out there and don't refer them. No, great question. I think the thing I love the most is just a good history and a good workup. But I understand that you're very busy out there, and we don't sit there tissing when we see the short referral letter. So, but any workup is gratefully received, really. Yeah, I think the biggest battle you guys have got is getting the referral to me, getting the referral through the various single points of entry, and or the multiple points of entry. Yeah, but yeah, I generally don't have many problems with referrals. I think they're great. I think you guys do a really good job.
So I think we might shift away from panic for now, but if you have any more questions, just pop them up and we can always come back as time allows. And our second topic we were going to discuss is, as I mentioned, Dan has a particular interest in geriatric psychiatry and an even more particular interest in delirium, or acute brain failure, as he's just educated me to call it. So I think, Dan, I thought you thought a good place to start was to actually look at the definition of this word that we use, you know, on a day-to-day basis, but actually it's often a good time in medicine just to step back and make sure that we're all talking about the same thing and what is actually going on.
Yeah, so delirium, it's one of my pet topics. I do quite a bit of teaching on this, but we all know that it's acute onset of cognitive impairment, I guess. I think the best way to think of delirium is as an acute brain failure. It's an organ of the body that's failing in an acute way, and chronic brain failure is a dementia. So it's easy to get an acute on chronic picture when you see a confused patient. So really, we're talking about, rather like dementia, I guess we all know this, as a progressive chronic cognitive impairment with functional decline. This is an acute cognitive change. And that's the basics of thinking about. I think if you think of it as acute brain failure, I think it helps a bit, rather than going into the many different definitions of delirium.
And I guess, you know, we're all pretty familiar with the workup of a patient with delirium. But I think it's always good to be reminded of the things that we should be thinking of and considering as the triggers or precipitants for that acute decline.
Yeah, I think, so the first thing is there's no investigation for delirium. There's no scan or a blood test or anything you can do, of course. You know, well, stepping back even further, first of all, if it is delirium, it's a medical emergency. And I often tell people this, and I think it's a medical emergency that's often completely missed. And I think it's around about 75% of patients in hospital will have a delirium. This is in Christchurch Public in one study, will have a delirium that's not identified. And I think that's improving, but it's pretty poor. And the outcome for untreated delirium is not good. You know, you double your risk of dying in the short term. I think it's something like 30, someone will know more detail, but something like 30% of patients with delirium in hospital will be dead within 6 months. But the hidden costs of delirium include brain damage, and I think people often don't recognize that often people are coming in with a bit of cognitive impairment, but after their delirium, they've got a new baseline that's significantly lower. So it's a very serious issue that's often not treated in a serious way. Now, I've forgotten what your question was, Matilda. I've gone off on a bit of a tangent, haven't I?
No, I think that what you're trying to express is that it's, you know, has so much morbidity and mortality that it's associated with, and it is such an important illness that can be missed. And I guess my question was the things that we should be considering as triggers, or perhaps the things that may be forgotten, that you see that are forgotten as potential triggers for that deterioration.
Okay, so brain failure, acute brain failure can occur can occur with anyone, right? But vulnerable brains are the most likely brains to become delirious. So people in ICU, young kids, and older people are the sort of three main groups I think of. So my patient load, they're very vulnerable to delirium. Precipitants for delirium are hugely variable, and you know, you read lists in books that are massive. And I guess the big precipitants, the big obvious ones include medication, infection, and they go from there, substance misuse, I guess, or withdrawal. but they can be as simple as having poor sleep, or recently losing a spouse and having to go for some respite and a rest home and a change of environment. The closer the brain is to the threshold of not coping, of tipping over, the easier it is to slip into delirium. And I think that having that idea of a threshold model is very, very helpful, actually. Yeah.
And I guess, Dan, we're taught, and it's very similar to panic attacks, that we should be utilising, or first addressing the underlying cause of what has precipitated the delirium, but then trying to utilise non-pharmacological approaches in the first instance to try and manage that patient's delirium. Can you just sort of cover some of what those kind of non-pharmacological strategies would be, and perhaps we'll get Mark to share some as well afterwards?
Yeah. So I might not have answered your question properly about the symptoms of delirium. Should I go back to that and then go to management? Yeah. So the way I teach this, and you'll get a different list wherever you look, but I teach I clap in time. This is and so the important aspects to that are the I is inattention, and that's I don't know if many of you have heard of the confusion assessment method. I think it's called a CAM. Inattention is very, very important. It's the most obvious deficit, I guess, cognitive deficit when it comes to delirium. And inattention is hard to understand. So it's important to think how would inattention express itself? When I'm talking to this patient, can they sustain a focus on what I'm saying? Have they demonstrated recently that they can remain reasonably focused to complete a series of tasks, or a number of, for example, getting dressed, or even eating a meal can be challenging just to stay focused and complete the task. So I'm looking for inattention. There's cognitive impairment. And cognitive impairment is complex, and there's a whole webinar on how to assess for dementia and what is cognitive impairment. But the things I'm looking for when I'm thinking about cognitive impairment are MOCA, but also the elements within, MOCA or an Addenbrooke's or whatever, mini-mental, but also the elements within that you see during the interview. So memory impairment, language problems, visuospatial executive deficits, and so on and so on. So there's cognitive stuff, functional stuff. This is global brain failure here, so neurological deficits, worsening sensory, worsening hearing, eyesight, proprioception, gait, all that stuff, behavioral changes. What have I missed there? A bit of psychiatry gets in there, but depression can be part of that cognitive impairment. And so the dementia assessment includes all those things. And within the assessment of delirium, you've got all that bunch of stuff that can suddenly appear, not chronically appear, but suddenly appear. There's level of consciousness changes, and usually most of the time people are hypoactively delirious. And not agitated, and that's why they're missed a lot of the time. And I've talked about affective change, which is normally a depressed affect with delirium. So often people say, my husband's acutely depressed, but actually they've got a hypoactive delirium with depression. And the P on the end of CLAP is perceptual disturbance. Often there's, typically visual hallucinations, but it can be anything. And then I put in the end, I clap in time, because those 5 things, the I, CLAP, all occur acutely. Those classic symptoms of delirium will suddenly occur, and they may fluctuate through the day. So, we've all probably been part of ward rounds where you arrive and the nighttime staff have told us that the patient was charging around causing trouble, and you go and see the patient, they're fine, and they're actually delirious, and they're fluctuating. So so it's really important to think about that. And I guess in the end, when it comes to identifying delirium, it's all about taking a good history. There's no investigations, like I say. You've got to understand the patient's baseline. So, and if the patient's confused, you need to take that history from a collateral source, you know, husband, wife, whatever, daughter, you name it, nurse. Find out what they're normally like. What were they like 2 weeks ago or a month ago compared to how they are now? You know, because it's very hard to know sometimes.
So I guess lots of those things overlap with someone who's developing dementia, but that differentiating feature being that acute deterioration and with a fluctuating course. And I think that I think that's a really important point, that hypoactive aspect to it, that they can quietly sit and kind of not cause disturbance on the ward, or although, you know, the patient who's agitated and causing chaos will probably get a lot more attention.
Yeah.
So that kind of, if we're able to recognise that patient, investigate them and treat potential causes, I guess the next step would be looking at the management and the non-pharmacological aspects of management.
Yeah, sorry, getting back to that. That's the crux of the treatment, actually. So it's, you know, we typically leap for the haloperidol, and I think that's a mistake most of the time. The problem with going for the antipsychotics is that they show that there's no improvement in the length of time the patient's delirious. It increases the risk of stroke, falls, you name it. That they're not good for older patients in particular, but sometimes we have to use them, particularly when the patient's really agitated. But stepping back to where we would ideally be focusing is on the non-pharmacological stuff. So what I think about is a brain that's sunk below its threshold, it can't cope anymore. You want to reduce the sensory stuff coming in, and you want to reduce the amount of work the brain has to do just to, you know, function day to day. So you reduce the demands on the brain. So the best way to do that, I think, is to put them, ideally, if you can, put them in a side room, or they'll need a hospital setting for the management of the delirium, because I think it can't usually be managed very well. This is always a debate, isn't it? But often can't be managed as well in another facility. Not always, but you know, usually it's a hospital setting. A side room's ideal. A diurnal pattern, so you know, light during the day, dark during the night. Familiar items around the person so they can orient themselves to who they are. Photos. There might be a clock or a calendar in the room. There might be a sign saying today's Thursday, you know, whatever. A family member is fantastic. Getting the patient up on their feet and, you know, if you can, and get them behaving like a normal person rather than being stuck in bed. But so I guess it's variable on depending on the resourcing you've got, but that's roughly where you want to aim. And then I think once you've got that set up, then you start doing the investigations, particularly looking at things like the medications they're on. Is there an anticholinergic load that can be reduced? You know, trying to reduce the amount of work that brain's doing as well. Is there anything they're withdrawing from? Any opiates that's just been started? Are they constipated? So on and so on. A common scenario for me is a patient is in a rest home. They become acutely disturbed, but the phone call is the patient's disturbed in some ways, agitated. They come into the emergency department and medically cleared, and sometimes sent back home again because there's no cause, no source of the delirium found. So it can't be delirium. And in fact, sometimes, here I go, I'm ranting now, but sometimes the doctor will say things like acute deterioration in their dementia. You know, just to me, that's completely, I don't know how to describe it. It's very frustrating when we should know that dementia is a slowly progressive illness. It doesn't suddenly get worse like that. It can't be anything else but delirium, and 50% of the time we'll never find what the cause of it is. But meanwhile, we can maintain their physiological state by making sure they remain hydrated and all the rest of it, keep them in a safe environment.
So I guess you want to, perhaps even when you can't find underlying cause, you want to optimize everything while whatever it is given an opportunity to resolve.
Yeah.
Mark, from your point of view, would you have anything to add from that point of view from management without drugs?
I think that's really interesting what Dan's saying there, and that it's that ability to recognise it early and just assume, to recognise that here's someone who is disorientated and confused and not themselves, and to pick up that history is quite challenging at times, especially when it's people we don't know. And I think exactly as you say, about trying to provide a quiet, calm environment and lots of reassurance and lots of routine. And I think that's one of the things that, although the rural hospitals, we sometimes feel we can't do the investigations that are necessary because we haven't found the cause, but we've recognised the syndrome, and actually we're quite well placed to have family present and have familiar environments. And no wonder about that balance between how far for us do we send people off on a journey of several hours into a busy ED department where they're away from family, balanced up against the ability to say, well, look, here's someone who just needs, as you say, good hydration, good routines in a safe space. And I think an awful lot can be done with that reassurance and having small numbers of staff and family working together. And the rural hospitals are pretty well placed to do that often, to welcome the family in and to help us manage their relative. And I mean, different hospitals have different protocols, but that's how I would approach it, and really trying to recruit the family into that and an understanding of that, and to get their help, because really that person probably will need one-to-one nursing, which is quite a stretch for the nursing teams. But if we can get the family as allies in that, they can often help us do that, I think. And that can be a good way of managing the confusion and the disorientation.
So from I'd like to think pragmatic point of view, but perhaps I'm being a devil's advocate, I'll give you a scenario on Taupo Hospital yesterday, which I'm sure you can all relate to. Chap, pubic rami fracture, on top of that, constipated, pneumonia, acute kidney injury, a little bit of cognitive impairment in the background, single RN on for the night, and a healthcare assistant and a full ward. So much as I would like to put in place all those strategies, and I do what I can, sometimes from a safety point of view and from a pressure from the people who are actually on the floor for the night, some drugs may be needed. Can you give us some ideas around what to select, dosing, and how to administer it?
So yeah, that's a common scenario that Matilda and I'm dishing them out all the time, and I always feel uneasy about it and wonder if I should quit and go and do something else. But haloperidol, none of the antipsychotics are any different, so that they're all the same, really. But the thing that I guess we know about haloperidol is it's been around forever. We understand it really well, and you can administer it in every different way, and so it's very practical. The only proviso is someone with Parkinson's or Lewy body dementia, and same thing as Parkinson's. And with them, quetiapine's my go-to initially in that acute setting. You might consider clozapine later on, but that's getting a bit serious for the, in the acute setting. But so haloperidol 0.5 BD, even 0.25 BD, really low doses, and see how that goes. And maybe increase it as high as up to 1 milligram BD is sort of roughly where I aim. Quetiapine, 12.5 milligrams BD, super low, and then keep working up if needed, and up to 25, sometimes 50 BD. I avoid benzos. I think benzos can be all right, particularly if there's alcohol, withdrawal delirium. They might be required, but they I think you too often cause too many problems. And from my memory with these older people, and from the Maudsley guidelines, it's like numbers needed to harm is 6 and numbers needed to treat is 9 or something. So you're going backwards, I think, with benzos with these patients. Yeah, any other questions about that? That's pretty much what I'd, if I have to sedate someone, I'll be leaning on the haloperidol first, I guess. Sometimes what you do, you get surprised, you give some haloperidol to someone with no history of Parkinson's or Lewy body dementia, and they get stiff and slow. So they might have it. It might be a first, you might have actually uncovered this. So then noticing that and switching to quetiapine to see if that helps. Another thing.
Mark, would you have anything to add from that from a drug point of view?
No, I think that would mirror what I would do, but I think that just that key thing about going really slowly and using very small amounts and frequent reviews, trying to keep the medication to a minimum. And sometimes it's not as instead of the reassurance and the quiet environment, is can we use a little bit of the medicine and then the quiet environment to get control of it? Because it's about safe management. It's not about a treatment for the condition. It's about safe management to allow treatment of the underlying cause. So as little as you can get away with, I think would be absolutely right, as Dan says.
And I think having your nursing staff on board and making sure that they understand your objectives as well, so you're sort of all on the same page.
Yes, and that can be a real winning hearts and minds sort of thing in a very difficult situation for the nursing staff often, isn't it?
See, Matilda, your situation, excuse me, where basically it's a staffing issue that results in iatrogenic harm to the patient, you know. I think it's a common scenario where we get forced into this. If you read all the latest evidence, the only treatment for delirium is non-pharmacological, and yet we're constantly doing this. We're taking a pharmacological approach. I think we've got a long way to go. I think we do a lot of harm, and masking someone's agitation or confusion with sedation, which is what we're doing with the antipsychotic, doesn't help treat the delirium at all. And I just see people on big wards with 6 other people all delirious, and if you're not delirious, you're going to be delirious and at the end of the night, and they're on antipsychotics and stuff. It's a bad bit of medicine, if you ask me. But resourcing issues, and maybe I don't know. It makes me, I lose a bit of sleep every now and then over this one.
Yeah, I think we can all share that.
Yeah.
I might just take that opportunity I've seen a few flicking messages in the chat. So Gary, anything you'd like to feed back to Mark and Dan with regards to questions?
Yeah, thanks, Matilda. There is a couple of questions here. Just a quick one initially, probably for Dan, around charting your haloperidol when you are forced to use it on a PRN or on a regular basis. Do you have any advice around that?
I always start low and go slow. What I tend to do is something like 0.25 milligrams BD regular, and add in another 0.25 BD PRN, but that it needs regular reviews. So the patient doesn't want to be over-sedated or under-treated, and with increasing risky behavior and stuff. So yeah, but I probably would pretty much double what I've given regularly as a PRN so that it's available if need be. That makes sense. So 0.5 BD, I'd give another 0.5 BD PRN. This is not guidelines, it's just my rough shot approach.
Someone's also asked, Dan, about that occasional situation where you have someone who is very acutely delirious and very aggressive with it, and you've got a massive, quite sudden behavioural problem on the ward.
Well, you need to sedate them. And guess you're talking about IM haloperidol, or a combination IM haloperidol and lorazepam or something like that, with close observations of their vitals and particularly their respiratory rate. So you get a bit of respiratory depression. So But yeah, I've had to do that before. 5 milligrams of haloperidol, you know, a decent whack, and usually they're asleep 10 or 15 minutes later. But security, staff, police, you name it.
The next question is for Mark. Mark, I mean, we sort of hear quite a lot about the number of times we miss particularly hypo alert deliriums. So when you're doing the ward round, because you're just on for the weekend in the Hokianga and it's a busy ward round, and you don't know the patients, is there anything that's sort of any clues or anything that you've got in the back of your mind as you do that around in terms of sort of missing those particular patients who we could easily pass by?
Yes, and I think if they're a little bit hypo alert, they're the ones that are quiet and don't get the attention, aren't they, and things. And I guess I think it's trying to engage people in that conversation and trying to just do that mini mental state exam or a mental state exam conversationally and seeing if they get that response, because you would expect to, and it's often the circumstantial talk around their situation that I think can help you pin that down more than the direct questioning, at least initially as a screening thing. And I think, as Dan says, also it's the fluctuation, and it's taking seriously the other people's reports of what was happening when you weren't there. That's the real key. I think the ones that we often miss are the ones where other people have been highlighting things, but we've happened to see them in a quiet patch, and we've not taken those other reports seriously. So particularly family and nursing staff, to really taking those reports seriously and picking and trying to, as Dan says, do that comparison between now and their baseline. And often that's only family that can really tell us that, or someone who knows them well. Is this, you know, so those are really important collateral histories to get. But a depressed response and a poorly responsive patient is always going to be a worry, I think.
Great, no, good. Thanks for that. There's one other question potentially for both of you, and that's sort of around the preventative sort of effects of some environments. I mean, someone's asked a question specifically about having a whānau room or a marae like you do in the Hokianga. But it certainly seems to be my experience a little bit over the years, as the ward has got busier and there is more alarms around, and there's more interventions going on and things, that that the number of patients developing delirium sort of is steadily increased. And I'm just wondering whether or not there is particular things about our environment that we can do that may actually be preventative in the first place.
Yeah, I think that's a great point. Yeah, I feel quite cognitively messed up when I walk in and out some of these wards with who knows what the alarms mean and people rushing around very busy places. And for the person that's come from home happily, you know, spending quiet evenings with their loved one, and suddenly they're in that environment, it's very tricky. So I think having I love the idea of a whānau room. I think that'd be awesome. That'd be a great idea in certain places. You'd still want some access by medical staff, I guess, but yeah, great idea.
Gary, in the interest of time, we might move on. But as I said, just keep popping questions in there. And I understand if people need to leave, we've been going for an hour, but we will move on to our next topic, which is just the small topic of suicide risk assessment. And the reason we thought we needed to address this, you know, it's a highly topical issue in New Zealand at the moment. We have staggeringly terrible statistics, and often in a rural setting, our access to an acute mental health team is often delayed from a time perspective or limited geographically because they're over the other side of a mountain range. And sometimes we're in the position that we need to make decisions around this. So I thought Mark, I thought if we started with you, and if you just gave us some of your kind of top tips around, approaching and interacting with a patient who's come in either acutely suicidal or following some kind of suicide attempt, connecting with them, and strategies for communication, I guess.
Yes, small topic, as you say. I think this is really challenging, and I think it does come back to the first thing for me is about establishing that therapeutic alliance and just trying to get an understanding and doing about what's brought them into the hospital that day, trying to really connect with them and understand their concerns and the pathway in. And I think that's often where I start is talking about the recent events in some detail and trying to get an understanding both of exactly what happened and what their thought processes were around that. And that can help, I think, both build the sort of therapeutic alliance and then but also give you a little bit of a sense of their recent history and planning and the exact nature of the events, and that can help with your risk assessment as to the seriousness of the attempts or the self-harm or the concerns about the self-harm that have brought people in, and about the ability for them to be safe and the situation that surrounds them at that time. I think then I think more and more I've come round to the idea that if you're asking about suicidal ideation and plans, it's safe and reasonable once you've got that therapeutic alliance just to ask. And ask, are people having thoughts of hurting themselves? Have they thought about ending their lives? And if so, plans, steps down that route, because there's quite a spectrum there, and there will be many, many people who have thoughts occasionally that life isn't worth living, right the way through to the point where someone's got a plan, written suicide notes, told people that they're not going to be there anymore. So trying to get a sense of where people are on that spectrum. Yeah, and I would do that by pretty frank questioning, and sometimes you get a little bit of resistance to that, but actually if you say and express that you're wanting to keep people safe and that's your role and that's why you're asking, I've very rarely had negative response to that, and often people express relief about being asked and being able to talk about these things that they felt very nervous and unable to talk about in previously. So I try and open up quite a sort of open space around that. We haven't got time really to kind of look at all the sort of risk factors for suicidality, and there's a whole load of stuff written about what those risk factors might be, but I do think it's worth mentioning both previous actions, so I'd always be asking about past history of that. Close connection with someone who's completed a suicide is a huge risk factor for then suicide, and there's the demographic things, and also just that cognitive sense of hopelessness. So those are the kind of issues I'd be wanting to address in that first conversation, and then going on to talk about what next. Where is safe? How can we keep you safe?
What was the last thing you mentioned? The cognitive. Just can you elaborate a bit on what you mean by cognitive hopelessness?
Yeah, so I think there is. Throughout that whole conversation, that there's a sense of what people's perception of the future would be, and whether people have some hope for things improving or they feel very hopeless about the future, and that's quite an important thing, and what their perception of what's going to happen next in the near future, what's going to happen over the next few days, where are you going from here, who's around for you, and those are quite important in terms of assessing their safety in the next, because often as rural hospital doctors or as GPs, we're really concerned about the next few days, about how we can get you safe over that period, sort of sense of time.
And I think when we were preparing for this, we discussed a bit with Mark and Dan around the assessment of suicide risk and trying to identify those patients who were at particularly high risk. And Dan made me feel slightly depressed in that there's no magical way of doing this. And even from a psychiatrist's point of view, this is an elusive thing. I don't know if you want to expand on that a bit, Dan.
I think that's a nice idea. I'm a little bit cynical about this suicide risk assessment, because I think I've heard some prominent speakers explain this in much more eloquent terms, but generally speaking, the proportion of high risk patients, the ones who are saying, I'm going to end my life tonight, I'm going to do it this way, if you let me go now, I'm going to end my life. The proportion of them that do end their life that night are extremely low. And I'm talking like, less than 1% low. It depends on the situation, of course, but it's very low. So predicting who will end their life and when is basically impossible. And the studies have shown that psychiatrists are no better at this than any other doctor, any person on the street, because of the low proportion that take that step. The greatest proportion of people that end their lives are in the low risk group, the ones that you wouldn't even potentially see or discuss it. So it's very fraught business, but I think it's still worth taking. I think, like Mark says, doing your best to build a rapport, and trying to be just frank and open. And I'm very, very straight with the questions these days. That I will often say things like, lots of people I meet who are in similar situations to you would have had thoughts that this is hopeless. Sometimes they might think that life's not even worth living. I'll be surprised if you haven't had those thoughts. Like, how are things for you at the moment? And people hardly ever would balk at that. Most people will respond to that. So any open questioning like that seems to work really well. I think the patients that worry me the most are the ones who present in a similar way to previous suicide attempts. So say they were psychotic and they ended their life, or tried to end their life last time, or they would back on the drink again, and there's a relationship breakup and they're doing that again, and it's very similar circumstances. They worry me. The ones that you can't build an easy rapport with and you're not sure of the history, they worry me a bit. And another example of that is someone who's cognitively impaired in some way. It's really hard to get a good grip on what they're thinking. People who are misusing substances and that are going to go home and misuse again, they worry me as well, because you're going to have even less executive function that night. And there was something else. I think if a patient can provide me with a reasonable plan, you get a good rapport, they give you a good plan, there's family involved, it all makes sense, and there's some future focus about how they're going to get out of this, then I start to feel more confident and be quite happy to, well, depends on the setting, but let them go home and see them the next day or something. But I realize I have to take a bigger risk, I think, than you guys, and I'm often sending people home who are saying they're going to end their life, which is common for me, and tricky. But I guess if I was in your situation in a rural location, I'd feel less easy about that. It's nice to share that risk with others. And if you're doing this by yourself, I'd tend to have a relatively lower threshold for involving a specialist mental health service of some sort.
So picking up from that, Mark, from what Dan's saying, from your experience, what are some practical tips you might have around that next step of, forming a plan with somebody, whether that be middle of the night stuff or over a weekend and things?
So I think exactly as Dan says, that ability to engage in the planning process and make some agreement about what next is really reassuring, and it's the people who you just can't engage with are often the ones that you feel most worried about. And I think making a follow-up plan that is agreed, that people will endorse themselves. I think if you can get to that point, really, it doesn't matter the details of that. It's the fact that you've got there that's really helpful. And I think one of the, much the same as any of the sort of physical conditions, one of the advantages we have in the rural hospitals is time and ability to use the ward there as a place of observation for a little while. And I think especially because a lot of our people go back to such isolated situations and often with means available, I'd have a very low threshold for using the ward as a place of safety while we're waiting, either for just a review and see how things feel the next day, or to recruit some specialist services or recruit family in if they'll agree with that, rather than sending someone off into the night to a farm that's isolated and has means of suicide there. I think is quite a high risk situation. And I think exactly as you say, Dan, as well, you know, our level of risk as GPs and rural hospital doctors is probably less than the risk that you can live with as a specialist service. And, you know, if we think someone might have cardiac condition, we'd often involve the cardiologists in making those decisions about how interventionist the treatment should be. And we'd often use the wards or the crisis teams to come and help us share that decision making, because it is very difficult decision making to make often.
I guess, could you, if you're in that setting, ring a crisis resolution service of some sort, discuss the case with a doctor on call, and then at least, you know, you discussed it with a colleague?
On a good day, that can happen. I think often, though, I don't know what other people's experience around the country, it'll probably be quite different. For us in rural Northland, often we struggle to get in touch with people who, in the short term, they're often some hours away. But what we can do is use our wards and family members to be a place of safety while we're waiting for that. And sometimes it's a question of leaving a message for the crisis team, who are too busy to even pick up the phone, but we're saying, look, we've got this person here, we'd really like you to come and see them over the next 24 hours. And that's almost the most common thing that I'll find myself saying to the crisis team, that they've come here, we've got them someone in a safe place, but we don't feel comfortable with them going home. We'd really like you to come and see them to help on that, with that level of assessment.
I think we'll take this opportunity to go to Gary, because people have been asking a few questions. I feel less depressed now, Dan. Now I sort of feel better. It's like we're pretty much as good as psychiatrists. I've changed my spin on it.
Yeah, and you could pull a person off the street and ask them, and they'd be just as good as well.
You, Gary.
Thanks, Matilda. Oh, and you've helpfully made it very obvious that it's a very hard thing to predict. But is there any particular alarm bells that would make you think that you shouldn't even sit on this patient on your general ward, and you know, acutely over the weekend, Mark, you should be thinking about getting them to a secure facility where someone can keep a constant eye on them, bearing the fact that, I mean, if someone decides to do a runner from one of our wards, or they're not secure places at all.
I think that's exactly right, isn't it? That we have to do an assessment of is this person safe to remain here while they're waiting for that, and we get caught out sometimes, and as Dan says, it's not possible to always predict what people will do. But I have, if we can't get in good engagement and we can't get that therapeutic alliance, and there's a level of agitation and distress there, that makes me worry. And that often makes me feel, actually, we need someone with this person one-on-one until there's that specialist assessment, maybe transfer there. And I think the other thing is, if people are telling, if we can get the therapeutic alliance, but they can't give us reassurances, I think almost the people that I do feel safe are the people I can get a good connection with and a good therapeutic alliance, who will say, yes, I will wait here. You know, and if they can say, yes, I can come and talk to the nurses if I'm feeling unsafe, and who will accept often a little bit of medication. But if you can't get to that point, then maybe we should be trying to move people on acutely.
It's not uncommon, Mark, for our nursing staff to feel particularly uncomfortable about some of these patients. Particularly, you know, they will feel that, you know, this is not a psych ward. It's not get up for this. And it may also be that some of our GP colleagues, when they ring in, will also sort of get that same message, you know, some of us who will say, well, you know, not really designed for that sort of patient. How strongly do you encourage your nurses and your other medical staff to look after some of these sorts of patients in this situation in the rural hospital?
I hesitate, I think, to speak for all rural hospitals or all rural primary care, because it is very different and the setups are different in different places. We're quite isolated where we are, and we're quite a long way from help. And I think that's probably true of most of the rural hospitals. And actually, it is our role to do that primary stabilization first aid for everyone, whether it's an orthopedic problem or a mental health problem or a cardiac problem. So actually, I would really strongly encourage the nursing staff and the other team that this is our role to make things at least stable and safe just now. But that might mean pulling in other resources, and we are often really thinly resourced. We often have on-call nurses who can come in, even healthcare assistants and family, and even, I mean, we've had times when we've called in fire brigade and called in members of the community to help us manage that while we're waiting for other help. And I think when primary care is almost more challenging, because they're open for a certain period of time and then closed, and they have to make a decision about, is this person safe to go home now, or how can we get people to come in and make that safe, and we at least are open overnight, and so there are people around who can provide a safe place and watch. I think so within our capacity to keep people safe, I would argue quite strongly that it is our role, at least in the short term, to provide a safe place while we're waiting for the specialist help.
Thanks, Mark. Gary, do you have any other questions there?
No, that's everything there. Thanks, Matilda. The only thing is, just going back a little bit, I can tell that quite a few people are keen for Dan's mnemonic, so we should grab that off him at the end and pop it on for Delerium, that is, on the leaning on fence post, perhaps. That's the only.
Cool. Yeah, we'll put that on leaning on fence post along with your resources, Mark. Mark, just firstly to you, when they're sort of drawing to an end now, are there sometimes when you've talked for a while, there's burning points that you think, gosh, I wish I'd said that back then? Is there anything that springs to mind that you feel like you would like to communicate?
I think talking a bit about the panic disorder, and I think just to go back to that idea that the panic and actually distress generally is often part of a bigger picture of an anxiety disorder or a mood disorder. And sometimes one of the things about the delirium and the agitation that people talk about, that agitation, to really wonder about the underlying cause of the agitation. And you know, often there's pain and fear and things in it mixed up with the delirium. And so it's trying to sort of address those and manage those. And one of the things, it takes time. You know, these absorb large amounts of our time and our humanity, and that can be very difficult in the context of a busy department, but they are often life-threatening. And I think those connections are really important to try and devote a bit of time to, and they're just as life-threatening as other conditions. And I'd really advocate that we need to try and set time aside to do those things well and properly. And often, even if it can't be immediately now, the reassurance that we will come back, you know, and not to leave those things hanging.
That's great, Mark, and I think that echoes what Dan was saying about that acuity, and that it does deserve our attention. Dan, how about with you?
Yeah, my main thing that I've been ruminating about is the acute sedation, and I was thinking everyone will have an acute sedation protocol wherever they work, I imagine. And you should, rather than just sleep in with 5 milligrams of haloperidol, which is the last thing I'd do, by the way, perhaps look at that and see. But this might, with acute agitation like that, with high risks, then this could be a good time to be thinking about benzos as well. Rather than using small doses for treating delirium, you're using it to treat this hyperarousal. You know. So that's just a point about that. My main thing that I'd love to get across, probably two things. One is I really admire all the work you guys do out there, and I often think when I get letters from people like yourselves that you're real doctors out there. I'm a shameful city slicker these days, and I'm surrounded by all these resources and support. So we know that you guys are working in a much harder environment and having to be quite shrewd in the way you manage. So that's something that I really respect, and I recognise a lot in the referrals that come from you guys. The last point, and probably my biggest point, is that if you ever see a confused patient, the first thing to do is to take a good history, and then you'll work out if it's acute confusion or not. And more too often I see people make the mistake of assuming that the confusion is baseline and this is actually a dementia or something, and it can be a real problem. A patient recently died 2 weeks after being sent home from ED with the case I was talking about, with the acute deterioration in their dementia. Yeah, take a good history. My final words.
That's great. That's what I'll be teaching my fourth year medical students in the morning. It's the fundamentals of everything we do. Well, thank you, Dan. At least all our egos feel as if they've had a slight boost this evening, if nothing else. Hopefully our knowledge as well. So that brings us to the end of our webinar this evening. And we've managed to get across the topics of panic attacks and acute delirium, and touched on some issues around suicide assessment. So a huge breadth of information. And I'll try and do some summary points, I think, this time, as some written summary points, because I think you guys have provided us with lots of real pearls. So thank you so much to Mark and Dan for lending us your time and your expertise. I think it was a really nice compliment of having Dan from the psychiatrist point of view, but Mark, you really provide us with that rural perspective and what it's like in our day-to-day practice. Thank you also to Gary and to Rory, who is our background tech man who sorts me out. And thank you to all of you for attending and for your great questions. And feel free to keep sending questions in to me. A few people wrote to me after last webinar, and I can pass them on to Mark or Dan if things crop up. And remember, you can pass this on to other colleagues to watch at a later date. And if I can just remind you to fill in the survey, that there's a link provided by Rory, just so we can pick up your medical council number to log your CME points, and also to gather your feedback for our next webinar. So our next webinar, the plan is for it to be in early May, and it'll be around stroke, and I'll get some details out to you shortly. Thank you very much to everyone. Ka kite anō.